Because here we go. So hi, everyone. Thank you so much for coming and being here. I see some familiar names from past sessions, so welcome back. For those of you who don't know me, my name's Jackie. I'm a fourth-year medical student down in Florida. Today, we're going to talk about valvular disease. I can send the link in there for you. 1 second. Let me just stop my share so you don't see anything weird on my screen. Let me copy that. Okay, that should work. And we are accepting responses on it. Okay, cool. There we go. Okay, now we're back. All right, so thank you guys so much for coming again. Like I said, my name's Jackie. I'm a fourth-year medical student. I'm really excited about this talk today. I think it's going to be a lot of fun. My passion is cardiology. I hope to make this interactive. As with other sessions, please ask questions. You can unmute yourself, or you can send messages either directly to me in private if you're not comfortable sharing with the group, or I encourage you to send it to everyone in the chat, so that way we can all kind of learn from everyone's thought processes. So this will be interactive. You don't have to participate, but I definitely encourage it. So this is what we're going to talk about today. Like this says, hopefully all of this will make a little more sense by the end of it. But these are some great echocardiograms of some valvular diseases that we're going to talk about today. So this is a backwards and upside down heart. So for those of you who have not attended a virtual round session, we're going to first do a case, physical exam, develop a differential diagnosis together, go through the assessment and plan, and then we'll talk about valvular disease together. So this is the SOAP note. I usually like to go through quickly and just make sure that everyone's on the same page about what the SOAP note is and what each of the sections represents. So quickly, I know some of you have been here before. I don't want to be tedious, but can someone just tell me quickly what types of things will go into the subjective part of the SOAP note? I know it's a little tedious. Yeah, exactly. Thank you, Seema. So these are the things that the patient tells you exactly. So if they say, I came in, my chest is hurting, I've been sweating for 3 days, something like that, that would go into subjective. ROS stands for review of systems. So this would be them saying, I feel feverish. Yeah, and Cole, you're exactly right as well. So this is also going to be the family history, their medical history, things that we're getting directly from the patient that they're telling us. Now, this differs from objective because, like it says here, objective things are not necessarily things that the patient tells us. So if I say, if I'm the patient and I say my stomach hurts, that would be a subjective complaint. But if I press on their stomach and they kind of, they wince, then that would be abdominal tenderness, and that would be an objective finding because that's something that I'm seeing in them that they're not telling us. In addition to that, so this is vital signs, physical exam, as I just said. So that would be me pressing on their stomach or listening to their heart. Additionally, tests, imaging, labs, those things are also objective because it's something that the patient can't, for lack of a better word, they couldn't fabricate it. It's kind of it's an objective truth about like, yeah, their arm is purple. That's just a fact. It's a purple arm. And then the assessment and plan will develop together. I hope that makes sense to everyone. So we like to start by this to see where people are. I think usually we got some people on the West Coast. I'm down here in Florida. If you want to click the annotate and then click a stamp, we can mark where we are. I'm right here by that little heart. Okay, nice. So we've got some people all over the West Coast, which is really cool. We got a bunch of people up on the Northeast, which is awesome. Someone's in Illinois. I'm from Chicago. I love Illinois. Best city in the world. Not biased at all. All right, awesome. I'm so happy to see people from all over the place. Thank you all for spending an hour with me today. I think it's going to be a lot of fun. I'm going to clear these drawings real quick because I'm excited to jump into the fun stuff. All right, so this is about Mr. Pena. I'm pretty sure this is a lady in the picture, but it's a stock image, so it was the best I could do. So Mr. Pena is an 83-year-old male with hypertension, hyperlipidemia, type 2 diabetes, and he presents to the ED following a syncopal episode. Does someone want to clarify what a syncopal episode is for me in the chat? Dizziness, yeah, kind of. So syncope, or we'll sometimes call it syncope, and that's basically passing out. So if I say he's status post a syncopal episode, that means that we're just after he passed out. So we might say dizziness preceding a syncopal episode for sure. Or you might say he has syncope, meaning he has passed out. You'll hear that a lot being thrown around by physicians. So we don't say passing out, we say syncope. Or some people say syncope, but I'm pretty sure it's syncope. It would with an E. So syncope, syncopal episode that occurred while he was bringing in the groceries. He did not hit his head, but his wife is unsure if he lost any consciousness when he fell. So per the wife, because he's just laying in bed right now in the ED, he's been fatigued for the past 6 months and has been complaining of chest tightness when he's walking up the stairs or for long periods of time. He's never passed out before today. So what are we focusing on here? What's important? I know this isn't the fun stuff, but this is virtual rounds. So for those of you who aren't in medical school or who are just trying to kind of test out the medical field, this is how rounds kind of go. We talk about the presentation of the patient and we kind of do a little bit of Q&A about it before we get into the pathology. So as tedious as this might feel, this is really kind of how the rounds would go in a hospital setting. So yes, I like this a lot. So management of meds, we definitely want to know how he's controlling all of these conditions. He's got high blood pressure, high cholesterol, and diabetes. And you're right, we definitely want to pay attention to the fact that he's got the diabetes because that's a huge risk factor for a ton of things. Yeah, Adam, he's got quite a few diagnoses, so that's really important. It's important that he passed out while he was bringing in groceries. That would be slightly different than if he passed out and he was just sitting on a couch watching TV. So we're now thinking maybe it has to do with the fact that he was kind of exerting himself. So things like that, starting to build a differential for why did he pass out? We want to make sure it's important. Why is it important that he didn't hit his head? That's a great question. So he has never passed out before today. This is his first syncopal episode. That's a great question because we want to know, does he have frequent falls? Does he maybe have epilepsy undiagnosed? Is he off balance because he's got something pressing on his brain? Great questions. There's a ton of different reasons people pass out. Yeah, and Cole, you're right. So it's important that he didn't hit his head because while a lot of EDs would probably might want to just precautionary scan his head, we may not need to scan his head, especially if his neuro exam is normal. So we want to make sure about that because even if he didn't pass out for a neurologic reason, he may have damaged his head. And we're not sure if he lost consciousness. For instance, if this was a seizure, then he would have been out of it for a couple of minutes. Or if he passed out for 10 minutes, that's way different than if he briefly fell, but didn't even lose consciousness and was like, whoa, did I just fall? That would be different too. So we're keeping all of those things in mind. And then this is really important. He wasn't perfectly healthy and then passed out. He's been kind of feeling really fatigued and he's had some chest tightness. So we want to keep that in mind too, to think, are these things related or did he just trip and fall? So those are the things that we're paying attention to here. So now I want you guys to generate some more specific questions for me. What are some more specific questions we might ask kind of based on these things? Or how might we phrase a question to Mrs. Pena while she's sitting in the waiting room? Like, what do we want to know about the syncope? What do we want to know about the chest pain? Someone mentioned medications. We'd love to know, is he taking meds for these things? Adam's saying, does the pain radiate or is it localized? That's a great question. So when someone comes in with a chief complaint, like someone mentioned, we want to make sure to characterize it. Is it a horse sitting on your chest? Is it a tearing pain, a ripping pain? Is it a pressure-like pain? And is it going up the neck, down the arm? Great questions to ask. Is it worse at night? Is a great question because it's oftentimes a very bad sign if things become worse when you're sleeping. So that's a great question to ask as well. Yes, excellent question, Seema. So we do want to know if he's had surgeries. He's got a lot of risk factors for a lot of things. Does he smoke is huge because he's got so many risk factors. Drinking, drug use, those would all go in the social history. Emily's asking if he has trouble breathing. Absolutely, we want to ask because the heart and the lung are neighbors. And so even if this is a cardiac problem, maybe his lungs are also bad, especially if he smokes. Great questions, guys. Anything else about this that we want to know? Maybe specific family history questions or any conditions we want to ask about if maybe his mom or dad has, or things we want to know about the syncope to kind of start to kind of start building a differential in our head, I mentioned a couple other things that can lead to syncope, like neurologic things or seizures. What types of questions might we ask to Mrs. Pena about to kind of characterize the syncope so we can start figuring it out? Yeah, we'd love to know if he has family history of heart disease, for sure. Had sudden cardiac death, um, any cardiac surgeries in the family. Like if his dad needed a transplant and had a heart attack at age of 30, that would be really significant because that's super young. No one should be having heart disease at that young age. Anything about the syncope else we want to ask? Eating habits throughout the day. Yeah, this is a great question because the most common cause of passing out is called vasovagal, which is like if you didn't drink water all day and you're really dehydrated, kind of, have you ever stood up too quickly and the room spins and you almost lose your balance? Well, when you're old, you can't catch yourself. You don't have sharper reflexes like when you're a little younger. And that kind of feeling of falling when you're dehydrated and you're not quite able to get blood up to your head quick enough, that can cause people to pass out rapidly. So for sure, maybe he was just dehydrated. That's a great question. I'll answer some of these questions for you now. So here are some things that you can use to flush out your kind of HPI subjective part of your SOAP note. So like I said in the other note, he's never lost consciousness before, didn't hit his head. He had no abnormal movements or loss of stool or urine. Now, why am I saying that? Does anyone know? Yes, exactly. So typically if someone is seizing, I don't know if anyone's ever seen someone having a seizure. I hope you haven't because it's really scary. You feel kind of helpless. So it's kind of, sometimes they'll tense their muscles or they'll be shaking their whole body depending on the kind of seizure. So he didn't seize, it doesn't look like. And many times with seizures, people will kind of lose their bowel ability to hold everything in. And so oftentimes if they haven't had loss of stool or urine, it's might not be a seizure. It puts it a little lower on the differential. So now for the chest pain, this is really important. So for chest pain, we always want to say, where is it? It was on the left side of his chest. We want to know if it's constant or intermittent, if it's different, if it's there all the time or it's only there. Like Mrs. Pena said, it was only there when he was bringing in groceries or walking upstairs or exerting himself. We call that exertional chest pain. And he describes it as pressure like. It doesn't radiate, like someone pointed out, it doesn't radiate. And it's a 6 out of 10 in intensity. If we can give something a numeric score, we like to do that. So 6 out of 10. These things were all on the other chart. These are just common medical abbreviations: hypertension for high blood pressure, hyperlipidemia for high cholesterol, and type 2 diabetes. Someone mentioned smoking history. So he has smoked for 40 years, but he's been trying to quit. And he drinks a few beers a week and no illicit drugs. No important family history, no surgeries. And he takes these 3 medications. You're not going to need to know these quite yet. I learned these in medical school. So these are just to control each of his chronic conditions. So he is taking medication to control all of his conditions. I know there's a lot of information here. Someone give me a thumbs up in the chat when you're ready to move to the next slide. 40 pack years, Cole, great question. No, this is just, so I didn't give it to you in pack years. This is a great question. So he's asking about pack years, which we use a lot in medicine. So a pack year is 1 pack smoked per year. So if I smoke 2 packs of cigarettes for 10 years, that would be 20 pack years. Now, but 20 pack years could also be I smoked 1 pack a day for 20 years. So it's not necessary, it correlates to the amount of time, but also how many cigarettes. I was telling people last week, I think I've known people who had pack years smoking up in the hundreds, not because they're 300 years old, but because they smoked an obscene amount of cigarette packs a day. So let's say for the sake of this case that it's 40 pack years of smoking. He was a 1 pack a day guy, but he is trying to quit. We got to give him credit for that. Great question. Good catch. Are we ready to move on, guys? I don't want to rush you. I can circle back to this slide at the end too if you want. Awesome. Thanks, Adam. All right, so here he is again. He's in no distress. He's AO times 4. Anyone here brushed with the medical field before and tell me what AO times 4 means? No harm if you didn't. I didn't learn this till medical school. Yeah, exactly. So it's alert and oriented to, and then the 4 is person, place, time, and situation. So this is when oftentimes people who are like EMTs are trained to ask people like, do you know who you are? Like, what's your name? Where are you? What year is it? They're asking that so they can make this determination of, do they know where they are? Do they know who they are? Because if I wake up and I'm like, yeah, I'm, a Russian dancer and I'm in a fort in Russia. I've literally had a psych patient give the most normal, oriented, story. He knew he was talking very logically. And then at the end, I was like, oh, I forgot to ask, do you know where you are? Where are you right now? And he goes, oh, I'm in a tent in Russia. And I was like, ooh, okay, so this has been deceptive. You don't know what's going on. And so it's important to ask these things. That's not Mr. Pena. That's just a funny story. So he is not febrile, meaning he doesn't have a fever. He's a little tachycardic. The upper limit is normally what for heart rate? Yes, it's 100. So we'd like it to be between 60 and 100. So it's a little high. He might just be stressed to be in the emergency room. This is definitely high. Does anyone know the normal for this? Yes, exactly. 120 over 80 is like perfect blood pressure. I don't even think I have 120 over 80 because I'm chronically stressed from med school. You will have high blood pressure too one day, probably. I hope not, but you might. So that would be perfect. He's a little high, especially since he's supposed to be on medication. So we don't really love that. Respiratory rate normally is around 16. So he's breathing about fine and he's setting 100% oxygen on RA means room air, meaning he doesn't have supplemental oxygen in his nose or through a mask. So EENT means ear, eyes, nose, and throat. So his pupils are equally round and reactive to light. I've put these two things in here. We grade muscle strength on a scale of 1 to 5 or 0 to 5 really. So 0 would be no tone in the muscles at all. And 5 is you've got full strength. You can like grip my hand and I feel it. So his neuro exam is basically normal is what I'm trying to say here. His pupils are fine. He doesn't have like a bleed in the brain. And his muscles are all moving fine too. So the chest, we care a lot about this. He's got a harsh systolic murmur with radiation to the carotids. We will talk about this murmur. For people who were here last week, we talked a little bit about it, but we'll talk more about this later. I'll expand on this in the coming slides. His lungs were clear bilaterally. So we know he smoked a ton, but his lungs are pretty much clear. So that means that he's not got any wheezing, no kind of watery sounds in the lungs, meaning that he's really congested back there. So it's likely not lungs what's plaguing him despite his smoking history. He's got good genes. And in his extremities, capillary refill, meaning if you were to press on your finger right now, kind of press it tightly and let it go, you should see it turn white and then it should get color back into it. In normal people, that should happen in less than 2 seconds. So if it takes 5 seconds to regain color in your finger after you squeeze it, that's a delayed capillary refill. And what do you think that might imply about their body? Why would a slow capillary refill be important for us to know? Poor blood flow, exactly, Cole. So someone who maybe is an uncontrolled diabetic, if I squeeze their toe, it might take a long time for them to get color back in their toe, or even if I have a lot of peripheral artery disease. So we definitely want to know that. Or someone who has lost a lot of blood from a gunshot wound, they're not going to be perfusing their fingertips very well. So their capillary refill would similarly be slow. So we do care about that for him. He's moving blood through his body, which is great. Oh, and also no edema. Edema means swelling. Does anyone know why we're looking for edema in the legs? This is a tricky question. But I trust you guys because you've nailed all of the other questions I've asked so far. Yeah, I like these a lot. So, and actually, you both are right, Adam and Seema. So, similarly, so I'll say two-pronged. So it is kind of having trouble pumping the blood back up. Everything wants to go down because of gravity. So if I'm having trouble pumping up the blood, then it could be a problem. It's usually a problem with the pump being the heart. So if the heart, or you're in like heart failure, then you're not going to move the blood up back, against gravity as well. And you can get swelling in the legs. So if he had edema, then that might point us more towards either he's got bad blood flow or he's got maybe heart failure picture. And then Seema saying DVT, which is huge. DVT being a deep venous thrombosis. These are extremely deadly, very common in patients who sit a lot or have risk factors, actually, like Mr. Pena does. That's usually only one leg is going to swell, because usually they'll happen on one side or the other. So if he had like one swollen red leg, that would super be concerning. So absolutely, we want to check to see if he's got swelling in the legs. Great job, guys. So now I'll ask you guys this: what types of lab imaging or other testing would you like to do for this patient now that you've seen his whole history and we've examined him? Yes, I would super like to get a chest X-ray and an echocardiogram for sure, especially since we heard a murmur. Anything else? Any labs we'd like to run, general labs or certain values we might look for? Yeah, we definitely want to get probably a CBC. So that's a complete blood count where we'll get the hemoglobin to know if he's got enough blood. We'll, like Adam is saying, we'll get white blood cells, which can be elevated in the setting of like infection. And a CMP is a metabolic panel. So that would tell us how his like sodium, potassium, and whatnot are, to make sure that he's not like super dehydrated or something like that. Seema is saying a head CT. Yeah, I'm not opposed to getting a head CT, especially since he passed out. And I don't want to say I don't trust Mrs. Pena, but if he did hit his head and we missed it, that would be on us. So we might want to do a head CT. Troponin is great. Troponin, we talked a little bit about this last week, but troponins are proteins that are contained in the heart muscles, the individual cells of the heart muscles. And so when those cells break down and die and apoptose, then they release the proteins that were inside of them. So in the setting of, say, a myocardial infarction or a heart attack, those cells are dying from lack of blood flow. And when they blow up, they release troponin. So if someone has positive troponins or high troponins, that usually implies they're having a heart attack. So we for sure want to check that for him, because he said chest tightness. D-dimer is a marker for DVT or deep venous thrombosis, like we talked about. We might like to get that as well. BNP is a marker for heart failure. If that's elevated, then it might imply that he has heart failure. So those are all great. Those are very good, guys. Any other? There's one more that you guys are missing. If we're looking at the heart and he's got some chest tightness, what's another type of test we can very quickly run in the emergency room for him? Yeah, exactly, guys. So an EKG is a great thing. It's quick and easy. They probably could have even done it in the emergency vehicle on the way to the hospital, just to see quickly if he's having a heart attack, because we need to get him immediately to be stented if that were the case. So here are his labs. So his CBC, or his complete blood count with the hemoglobin and the white blood cells, are all normal. So no infection, no anemia. All of his electrolytes were normal. He's got very low troponin. So this is great. This means he's probably not having a heart attack. This is normal. And his BNP is below 200. We like it to be below 100. So this is a little bit inconclusive. It's probably fine though. I mean, it might be a little high. So, but it's not, if it were in like the 500s, then that would be really concerning, but he probably would have had edema in the legs. And then these are the imaging that I probably would have wanted immediately from him. I would have wanted the EKG. This should have been first. And then the chest X-ray, and then probably the echocardiogram because of his murmur. And then because he was having that kind of exertional chest pain, I don't know if you guys have ever seen people run on the treadmill in the doctor's office with the leads on their chest. That's a stress test. So that means that we're going to put you through kind of exercises to stress your heart out as if you were exercising. And then we're going to see if any areas of the heart aren't getting enough blood when you're exercising, when the heart is pumping super hard. So if that were the case, because he was having the exertional chest pain, it might be good for us to see kind of if he is kind of having transient, we call that angina, like with that chest pain, we're putting him at risk for a heart attack in the future. Might want to do that. Not now because he's got other issues, but maybe in the future. So this is his imaging. This is not a talk about EKGs. We went through the bare bones basics of it last week. I might want to do like an advanced EKG another time if you guys want to learn a little bit more about some of the cool patterns. But let's just quickly look at this chest x-ray. Do you guys see anything of note on here? Not expecting you to be a radiologist, but what do we see on the chest x-ray? Anything? It's okay if you don't. I'm actually not the best at chest x-rays. I'm no radiologist. Do the lungs look pretty clear? Heart's maybe a little enlarged. Yeah, you know what? I think that I agree that maybe it's a little big. So in general, guys, we'd like the heart to be less than half of the width of the chest. So if the chest is here to here, this is about half, maybe slightly larger. The left chest is a little smaller. It is a little smaller, but that's okay because the heart usually sits a little more to the left. And then we have, I would call these clear lungs. So we've got clear lungs, no fractures, open trachea here, and the cardiac silhouette is what we call this, is not enlarged. Okay, so that's a great point. Someone is asking if these are ST elevations, which would be indicative of a heart attack. I would not necessarily call these ST elevations. They do look a little peaked. Mr. Pena is not having a heart attack. I might have picked a poor EKG. The most important thing here to note, guys, if you wanted to make a note about what his EKG showed, we call this left axis deviation, which just means that if you can see here, this is a nice normal QRS complex. It's just a little tiny peak going up. These guys are like, whoa, they're huge. They're like really long and tall, and they're kind of crowding out some of these other leads. They're not supposed to be this tight and this sharp, like this, kind of intruding on the other people. And so this isn't a talk on EKGs, but basically if the heart muscle becomes kind of too thick on one side, or is kind of doing too much on one side, then sometimes these cameras or these leads that are looking at that side of the heart become longer to kind of show that this side of the heart is doing a lot more than it normally is doing. And so these leads represent the left side of the heart. So this is a left axis because it's the left side of the heart. Deviation, meaning the heart is doing the most on the left side. So that's what we see there. I think that's very astute of you to notice these. These might be little ST elevations, but I wouldn't want you to document that because Mr. Pena is not having an MI right now. I might have picked a poor EKG. This guy, I'd probably redo the EKG to make sure. His troponins were negative though, which is good. So we also got an echocardiogram of him. I'm not expecting you guys to be cardiologists and learn how to see these. This takes a lot of practice, but basically, this is a snapshot of just a piece of his heart. We're going to talk through the anatomy quickly. So it's okay if this is a little confusing and overwhelming, but this is the aortic valve, which connects the left ventricle and the aorta. And so this is a little thick here is what we're seeing. But again, not expecting you guys to be cardiologists. So what would you guys put on his differential diagnosis, kind of given everything that we've seen, taken his case as a whole? It's okay to be broad. You can be specific, however you want to do it. Aortic valve disease, yeah, I would definitely agree. I know that that was a bit of a gimme because we saw the thickened aortic valve. Anything else? I mean, you did mention those ST segments. I mean, we might not want to necessarily rule out like angina, which is why I was saying maybe doing a stress test in the future could be beneficial for him, just to kind of see if he's at risk for a heart attack in the future. I realize this was a bit of a gimme. I'm just going to put these on here now so we can start talking about the valvular disease. So maybe myocardial infarction based on that EKG, but his troponins were negative, so that's definitely lower on the differential. No need to rush him to the cath lab. Aortic stenosis is certainly up there, or aortic valve disease. COPD, his lungs were clear and he didn't have any wheezing, but he has smoked for 40 years, so potentially could be lung, again, very low in the differential. And then someone mentioned, is he drinking water? Is he eating? So vasovagal syncope, perhaps he passed out because he was really dehydrated, but his blood pressure was quite high when he arrived. So that's also much lower on the differential. Okay, so here's our assessment and plan. Sometimes I forget to do the assessment statement, but I remembered it this time. So we like to sum up the case, pulling all the pertinent things. So my summary statement for Mr. Pena would be that he's an 83-year-old male, history of exertional chest pain, presented to the ED following a syncopal episode without prodrome. Prodrome, for anyone who's ever passed out, it's kind of that feeling of like, oh, the room is spinning. Maybe I hear a ringing in my ear. I'm seeing flashing lights. We call that a prodrome of like, I'm sure I'm about to pass out. I need to sit down. So he didn't have a prodrome. So that means it's probably not a seizure. So without prodrome is important for that reason. Echocardiogram and EKG are most consistent with aortic stenosis, as we saw. That was a thickened aortic valve. And left ventricular hypertrophy, meaning that left ventricle is gotten kind of thick and is overworked, which is why we had that left axis deviation on the EKG. So we wanted to do the echocardiogram from him. We're going to need a little bit more than what we saw. We like to do an echocardiogram with flow through the valve. So that takes a dynamic picture like we saw on that first slide that I showed. It takes a dynamic picture of the valve so we can really see if it's a stiff valve, how stiff is it? And then we want to talk to cardiology because he might need a valve replacement, especially if he's passing out. And then as far as other things, we can't ignore all of his other, we call them comorbid conditions, or the other things that he has. So his hypertension, we want to recommend the DASH diet. I was pimped on this question during rounds. Does anyone know what DASH stands for? It's kind of silly once I tell you, if you don't know it already. Yeah, it is a low salt diet, but it actually means dietary approach to stop hypertension, which is kind of a silly acronym, I thought. But it's the DASH diet. So it's the diet that we put patients who have hypertension. And basically it's like a low salt, low carb diet, just kind of generally eating healthy, but that's what we call it as a fun fact. I think that's funny too. I was, they asked me that in the hospital during rounds and I was like, oh, it means like diet. And I thought it like stood for the types of foods. And then they were like, no, it's the dietary approach to stop hypertension. And I was like, sometimes these medical people, I don't know how they name things. And then we might want to add a diuretic just because he's kind of got some heart issues. And so diuretics are, some people call them water pills. So he would basically just kind of pee a lot to get some of the fluid off. And so if he's got hypertension and some kind of concomitant heart disease, perhaps we want to get some of the fluid off to make his heart not have to work as hard. We want him to continue taking the medications for each of these two conditions. And then we do want to make sure, he said he was stopping smoking, but after 40 years, we just want to make sure that he's really stopping the smoking. Okay, so now we get to move into the fun part. So we're going to talk about heart anatomy first, and then we're going to talk about valve disease. So first thing I want to talk about is just the general flow of blood. So what happens is you take a breath in, air comes into your lungs on either side. So here, all three of these and all three of these connect to the lungs on either side. So I take a breath in, blood goes into the lungs through here. So this would be deoxygenated blood goes into the lungs. It gets filled with oxygen in the lungs. And then oxygenated blood comes back through the pulmonary vein into the left atria, down the mitral valve, into the left ventricle, up the aortic valve, and then out into the rest of the body from here. So this is the valve, Mr. Pena. We're concerned about this aortic valve here. And then again, as that blood goes out into the body, it perfuses all of the tissues, and then it comes back to the heart from the legs, and these come from the arms and the head into the right atrium here, and then down the tricuspid valve, up the pulmonary artery, and then back into the lungs to get oxygen again. So that's just the general flow of oxygen. We call it the left heart is the oxygenated side, and the right heart is the deoxygenated side. This is a cool picture. So imagine I took a knife and I cut the heart like this, like straight across like this way. So this is us looking at the valves from the top if I'm looking down at a cut open heart. So these aortic valves are coming towards me. So blood again is going to come up through this valve into the aorta. Blood will similarly come up through this valve into the lungs. And then this is blood. These are the two atria here. So this is blood going down into the right ventricle, and this is blood going down into the left ventricle here. So I think this is a cool picture to see. And some of these arteries here, actually, interestingly enough, are the ones that get plugged up in a heart attack. So you can see here, they're coming right off of the aorta, and these vessels supply blood to the heart because the aorta is bringing blood everywhere else. So now I want to talk about heart sounds. And does anyone know how many heart sounds there normally are supposed to be and what they represent? There are two. Yep, we get the lub-dub. We call them S1 and S2. And what do they represent? What's causing those sounds? Valves closing. Emily, you are 100% right. And Fawaz, you're not wrong. We're going to talk about systolic and diastolic in a second for sure. Those are phases of the heart cycle. So importantly, I want you guys to know that the closing of these valves, because notice that these are all one-way valves, when they close and they snap shut, that's what makes our heart sounds. So yeah, here they are. So we have our S1 is what we call it, is our first heart sound, and our S2, this is the lub and this is the dub, is S2 is these two valves closing. So these two come as a pair and these two come as a pair, and they are valve closing. I hope that makes sense. So again, that would be these two are one and these two are two. So here's just a little bit about the valves. I'm not going to read all of these to you, but again, here they are. So there's two general ways that we can have dysfunctional valves. Either they can be too stiff, we call that stenotic valves, like aortic stenosis, or they can be too floppy, meaning if they're too stiff, that means that blood kind of isn't able to get through them. And if they're too floppy, then that means, like I mentioned, they're one-way valves. So the blood is supposed to open. For instance, blood would be coming down from the left atria to go through this valve downwards, like into the page, into the left ventricle, and then it's supposed to close. And then the heart's going to pump the blood back up through the aorta into the body. But if this valve didn't work, and then I go to pump the blood through here, some blood might regurgitate back through this valve when it's supposed to be shut. And then, so my one-way valve wouldn't be working in that case. So that's a regurgitant valve. So we can have two types of valve disease for pretty much all of these valves. We can have, for instance, aortic stenosis and aortic regurgitation. Similarly, we can have mitral stenosis or mitral regurgitation. So now someone had mentioned systole versus diastole. So let's talk about that quickly before we get into these questions. So diastole is, imagine the heart getting relaxed. This is the heart trying to fill. So as you can see here, which of these two valves are open during diastole? Mitral and the tricuspid, that's correct. So we have these two valves are open during diastole. So we're trying to fill these two ventricles down here, meaning these two valves are meant to be closed because two are open at a time always. So they relax, we fill with blood, and then the heart contracts. And then it pushes blood out through these two valves, and that's called systole, which is when these two valves open. And that means these two valves need to be closed. So imagine if we had, now let's do this question. If we have, what type of murmur would the mitral valve make during diastole? Would it be a stenotic valve or a regurgitant valve? So imagine that we're in diastole here. Look at this picture. If we're hearing a murmur, meaning we're hearing kind of abnormal flow through the valve, do you think that this would be, we would hear a murmur here because it was too stiff or because it was too floppy and therefore blood was regurgitating through it when it shouldn't be? Would it be a stenotic mitral valve or a regurgitant mitral valve? Yeah. Okay. So we're seeing a little bit of a little mixed answers, but you guys are right for the most part. So this would be stenotic. For these two valves, if we're hearing a murmur during diastole, then we would be hearing the murmur of a stenotic valve, meaning this valve was too stiff. So I'm hearing blood rush through it when I really shouldn't be hearing blood rush through it. Similarly, if I heard a mitral valve murmur during systole, that would be my regurgitant or my floppy murmur, mitral regurgitation, because this valve is meant to be closed. So when I push against, when I contract the heart muscle, blood only goes up through the aorta. But if I happen to get some blood backflow through here, that would mean that this valve is too floppy and blood is sneaking back through this way. So that would be the murmur of mitral regurgitation. I hope that makes sense, where we can hear two different types of murmurs for two different types of valve disease, depending on where we are in the heart cycle. Good job, guys. These are really tough questions. These are medical school level questions. So if you guys are gripping these already, you're way ahead of the game. Let's do this one now. So Mr. Pena has a systolic murmur. So he's over here. So what do we think is wrong with his aortic valve? Is it stenotic or is it regurgitant, given that we hear the murmur during systole? Stenotic, perfect. Yeah, exactly. So he has aortic stenosis because we hear it during systole, exactly. Similarly, if we heard a murmur during diastole, when these valves are meant to be closed, that would be the murmur of aortic regurgitation. I hope that makes sense. These are pretty confusing concepts, so stop me if I need to go back through it. So now we're going to talk about aortic stenosis. So here we can see an aortic valve. This is an echocardiogram. We call this the Mercedes-Benz sign when you can see kind of the stenotic valve because it looks like a little Mercedes-Benz. So it's not supposed to be this light and bright. So that usually means it's calcified, usually just from age. We call that senile aortic stenosis. So if you can see it like that, that's usually not a good sign. So it's the most common valvular heart disease in industrialized countries, just because as people eat bad diets and as people age, kind of everything in the body gets a little bit broken down as you age, just it kind of wear and tear. So as that valve has been doing work for your whole life, it gets a little bit calcified. It's kind of like people get osteoporosis in their joints from overuse. This is kind of like the osteoporosis of the heart. You can think of it. So it's a narrowing of the aortic valve, resulting in an outflow blood obstruction. So blood then is not able to get into the aorta as easily. It's being trapped by this kind of really stiff valve. So here it's saying patients may be asymptomatic for a long time, so it's often detected late. So lots of elderly people have aortic stenosis, but many of them, they don't know it because we call it subclinical, but that doesn't mean they don't have aortic stenosis. So oftentimes the first way that we see it is quite late in the disease progression, like with Mr. Pena, and it's dyspnea on exertion, which is kind of, I feel out of breath when I'm walking. Angina, that's that exertional chest pain, or syncope. So imagine if I'm trying to pump the blood out through the, let me go back. Imagine I'm trying to pump blood out this way to get to the rest of the body. This one goes, these guys go up into the head and neck to get up into the head. So if I'm not getting blood into the head as quickly, you're going to pass out, right? That makes a lot of sense. I'm going to pass out because I'm not getting blood out. I literally have an obstruction preventing heart from getting out to the rest of the body. Now, why do I have chest pain? Why do I have chest pain? If I'm not able to push blood out through this valve, guess what else doesn't get blood out? This little vessel here is above the valve. So again, if I'm having trouble getting stuff out through this valve, I'm not going to be perfusing the heart muscle itself very well. And that's why it almost kind of looks a little like a heart attack. It's not because there's a clot though in the vessel. It's because I'm just not getting a ton of blood out to the heart muscle itself. So that's why it can present kind of like a heart attack, which is kind of cool. I feel like all of these symptoms make a lot of sense once you understand the disease. So when we listen to his heart, we see that harsh systolic murmur, like we talked about. When we understand now why it's in systole, it radiates to the carotids, which are those two big vessels up in the neck. And we hear the murmur all the way up there because those vessels come kind of directly off of the aorta. So the sound kind of reverberates up into those carotids, which is why we can hear it there too. And the best way to diagnose these things, of course, is by echocardiography. That gives us a dynamic picture of the heart muscle. An EKG, like we all saw, only shows us that we have a thickened muscle on the left side of the heart, probably just from overuse. It's pumping against an obstruction. So that would be why it's a little bit bigger, but that's not diagnostic for aortic stenosis, nor is a chest x-ray, because we didn't really see anything there. So how do we treat this? For especially Mr. Pena, who is our patient still. So aortic stenosis is often treated conservatively, meaning we often don't do anything for it if you're not having symptoms. So say I do an echocardiogram of someone who's a little older, they have no symptoms, they can run, walk down the block, no issues, but we see that their valve isn't really opening well. We don't really do much for them. We'll make sure that if they have high blood pressure that we monitor it. So we're not creating more work for the heart than we need to, but in general, if we don't have to treat it, we don't. However, for someone like Mr. Pena, who is experiencing symptoms, he passed out, he's older, if he'd broken a hip, he could be in the hospital for months. We probably do need to replace his valve as a definitive treatment. So we have a couple options for how we can treat this valve. We can do a replacement with a surgery, like a full surgery through open heart, or we can do a transcatheter valve replacement, which is becoming more or less the gold standard these days. And so fun fact, these TAVRs, we call them, are usually done by cardiologists, not by cardiac surgeons. So cardiac surgeons are slowly getting their jobs taken over, which is kind of fun. So this is what they look like. This is the valve before it's put into the patient, which I think is cool to see what it really looks like. So here's some more pictures and here's a little bit more about it. So surgical AVR, which is the one where we do the open heart surgery. This is recommended for patients who aren't really at surgical risk. So people who are not Mr. Pena. So if I was 45 years old and I didn't have hypertension, I was pretty much healthy, but my aortic valve disease, I have bad genetics, I just have a bad valve. You might want to do a surgical repair on me because I'm definitely going to be fine throughout this surgery. Or if I have like concomitant conditions in my heart, I have the aortic stenosis, but I also have a lot of clots in my coronary vessels that supply the heart. If I had presented with aortic stenosis and then you also find that I came in really for a heart attack though, you might want to do this just so you can kind of correct everything at once. But for someone like Mr. Pena, I would probably do a TAVR. Because he's kind of got really bad surgical risk because he's quite old. He's got a lot of comorbid conditions. And we do think he's going to live for more than 12 months. I really hope. So I think that's probably what I would recommend for him in my plan. So this is what it looks like. It's pretty cool. It comes up through the descending aorta, back through here, back through the aortic valve. And we just kind of plop a new valve in there. It's pretty cool. They'll have one little incision on the leg and these patients can usually go home like pretty quickly. It's not an open heart surgery. So this is becoming more or less what we like to do for patients now. Now, I think this is the coolest picture and we'll end on this. This is them. We call this parachuting down a valve. This is an open heart surgery. So what they do is they take this new valve, they put like 1 million stitches around where this valve sits in the heart. So around here, they'll put a bunch of stitches in, and then they'll put those same stitches up here in the heart. And usually it takes 2 surgeons. And then at the same time, they'll take all the strings and they will parachute it down and it just kind of slowly descends into the hole. And then they tie maybe 20 knots or so around this valve. It's pretty cool. If you ever get the chance to see one, I highly recommend it. It's really the coolest thing. And so this is what that looks like. So these are the 2 options that we have for him. These are my sources, and I'm more than happy to go back, talk through some things. We can talk about some different types of murmurs if you want. I'm here to answer any questions or, help you guys however you need. I will stick around for the rest of the hour. But I hope you guys have enjoyed this talk. I've had a lot of fun giving it to you.